Betsy, Bets, Bets. She's on my dresser.
Welcome to Samaritans Purse International Health Forum. We're so glad you're able to join us today. We hope you all participate in our conversation today. You can chat with us in the group chat box to the right of your screen. So please feel free to put your comments and questions there and we can address them. Just want to start today's presentation by lifting it up in prayer. It's an important topic we're discussing today, and so if you'll just pray with me for a minute, we'll start our conversation shortly. Father God, we come before you this morning, and we thank you for the opportunity to learn and grow. Lord, we pray that you would speak to us, give Dr. Tom the words to say, and Father, we just pray that all the technical issues will work well with this webinar, and Lord, we just give up this important topic to you today and ask that we would just be learners and that we would just hear what you have to say to us today. In your name we pray. Amen. I just want to introduce Dr. Tom Wood to you today. We're excited to have him speak with us and share with us. Dr. Tom Wood is an epidemiologist with more than 50 years experience in serving in diverse environments across Asia, Africa, Latin America, and the Caribbean. He's a graduate of Johns Hopkins University's School of Hygiene and Public Health and has worked inside disease outbreaks around the world, including the post-earthquake Haiti cholera epidemic and Ebola. Dr. Wood has served as the Director of International Health Programs at Samaritans Purse and was Director of Manpower for 8 medical research facilities. He has also served as the Public Health Officer for our county health departments and was the Director of Occupational Health at 2 major U.S. regional medical centers. So we're pleased to have Dr. Wood present to us today. We know we can learn a lot from his experience, and you know, the explosive just nature of this epidemic is, and the concern for congenital birth defects has really brought this to the forefront of the conversation. So Dr. Wood, we're excited to have you with us. Thanks for sharing with us today. You can go ahead and begin your presentation.
Well, good morning. I'm glad to be here. I'm glad to have this opportunity. The evening has been a rough one. Things in life of an epidemiologist, sometimes we go for months without much to do, but then all of a sudden we get a lot to do. And so we've been following Zika for a while, and I'll go into a little bit of why that kind of snuck up on everybody. But just for an example, last night we're now dealing with the potential for a Lassa outbreak in Togo and helping one of our mission hospitals over there. So I was up for a good part of the night dealing with that. But we're going to let that one go for now, and we're going to go over to Zika. So if we could start with a slide presentation. The Zika virus, as you know, it's just one of the emerging infectious diseases. And I thought, I found a quote by Solomon Bayless and Brown in a journal. It's an online journal called Lancet Infectious Diseases, and I think the quote is, speaks very well to as a lead-in to where we want to go today. And I'm just going to read it for us, and it says, "The early part of the 21st century has seen an unparalleled number of emerging infectious disease events. West Nile virus across the Americas, severe acute respiratory syndrome in China, which we all know as SARS, chikungunya, which entered the Caribbean last year or the year before and has spread rapidly around the world, the avian flus that are out there now, H7N9 and H5N1, the Middle East respiratory syndrome, which we would know better as MERS, which is in Saudi Arabia and has gotten out from Saudi Arabia a couple of times, particularly into some parts of the Philippines. And then, of course, the big one that caught everybody's attention, and that's Ebola and the outbreak that occurred in West Africa. We spent, as Samaritans per se, a good amount of resources and time and investment in interceding with very successfully, I should say, with that outbreak in Liberia. It's not that it didn't cost a lot of lives, but some of the things we'll talk about today apply directly back to what happened with Ebola virus. And they go on to say that so many of these emerging infectious diseases have come up that, in fact, we should probably no longer consider them extraordinary. There are influences that have contributed to that. Not that there are more diseases. I think in epidemiology we deal with a triad, which is called the epidemiology triad, and which is host, agent, and environment. And the new thing that has been introduced, among us now today is the rapidity with which we travel around the world. Go to the next slide. Yeah. What this has done is it's created a challenge for healthcare workers and for the susceptible public, across the board. For example, a large part of what happened with Ebola that made it different for West Africa than we have seen in ongoing Ebola outbreaks across Africa before that is they were largely, the previous ones were largely limited to small villages, and when I say small, I'm talking about maybe 100, 200 people. And because of the isolation of those villages, the outbreak stayed fairly localized. We got the healthcare workers who would come in, of course, and pick that up also because they didn't know what they were dealing with. But when it got into this time into Guinea, and then from Guinea into Haiti and Sierra Leone, not Haiti, to Liberia and Sierra Leone, we had the fact that Africa, and particularly West Africa, has evolved to the point where transportation between cities along roads is very readily available, and people seeking care and running from this dreaded disease were very easily able to get on the back of a motorcycle and go from a fairly remote area into a highly suburban or urban environment with a lot of people in close proximity very rapidly. In fact, we're very well aware of one young lady who came to up to the Foya area to receive treatment for Ebola, was unable to be admitted there, and rode in the back of a motorcycle taxi then into the capital of Monrovia, and the disease was then introduced by her into that area, and we saw the results of that. it's we're just highly mobile. And next slide on that. The one I would like to focus on a little bit, and it kind of shows you what can happen, is I was the public health officer for a large county out in Colorado, second largest county, largest land area, second largest population for Colorado. When I picked up a news article about birds that were dying at LaGuardia in New York around the airport, and and they at the time didn't know what was causing this die-off of those birds. Well, what it was the introduction of West Nile virus, and tracing that back, it appears that a lone Culex mosquito that was infected with the West Nile got into the cargo hold of an El Al airplane in Israel, and when that plane opened up, it happened to be sitting in New York in a good environment with a lot of birds on the tarmac. Was found a very readily available blood meal among those birds, and the outbreak started. When that outbreak started, I looked at that, and I was in Colorado, and that was New York. We knew that it would come across the United States because Culex is a very common mosquito in the United States, and we knew it would come. I predicted that it would arrive in Colorado in about 5 years from the time that it was introduced, when in fact it arrived there in 3. And now then, West Nile virus is endemic throughout the United States in areas where Culex mosquitoes occur. I'm now in south central Texas, just outside of Austin, and every year here, when mosquito season comes into play, we have to be careful of exposure to Culex, because it was just 2 years ago now that they had a pretty major recurrence of the disease here in Texas. So it's the things that we look out for. But again, it was a mosquito picked up in the cargo hold and transported halfway around the world, very quickly, and released into the environment, where there was a nice population of birds and man, and it was a fertile ground for rapid spread of this emerging virus. Next slide. And that kind of brings us to Zika virus, and I've got to be careful with that because I'm in a Hispanic population here, and the lady who helps my wife clean her house about every 2 weeks is named Zita. And so, but dealing with Zika virus is not new. It's been around a while. We'll go a little bit into its history. But it arrived in the Americas by a very circuitous route, but it is here now. And the thing is that what caught us by surprise with this one is up until recent history with it, it was thought to be a fairly benign virus, in that 80% of the people did not show signs of infection when they had been exposed, and then the infection was quite often very mild. And so, it arrived, and we said, oh yeah, well, it's here now, but not a big deal. And as it turns out, it has brought with it other things that are a big deal. Next slide. It's been around for a while, as I said, and it was first isolated as an infectious agent in 1947 in the Zika National Forest in Uganda. And if you look at the map on the right-hand side there, you'll see that the Zika National Forest is located in the southern part of Uganda along the northern shores of Lake Victoria. And the scientists at the time, the medical researchers at the time, were trying to follow a outbreak of yellow fever, and to trace how it made its way around the shores of Lake Victoria. And one of the ways of doing that was to take rhesus monkeys and put them out, expose them in various levels of the tropical jungle to see. One is what was the mosquito that was transferring the yellow fever, but also to see, where it was at, because they're very susceptible to yellow fever. Quickly show symptoms and are rapid multipliers of the virus. So they made at the time good sentinel animals. But one of the animals became sick, did not follow the normal trajectory of a yellow fever. And so when they started looking and were able through tissue culture to isolate this particular virus, it was a new virus for them at the time, which they did name Zika after the area that it came out of. Next slide. Zika went little noticed because it appeared in this monkey then for until 1952-54 time frame. And at the time, a couple of things happened that brought greater attention to it. One was that in Nigeria, they actually isolated the virus from 3 individuals, one being a young girl. But in a national serum survey that they were taking in India, they showed that neutralizing antibody to Zika virus in a large number of people. So having that neutralizing antibody there meant that the virus had been there. Nobody knows how long, but we do know that the virus had made it somehow, either from India, back across to Africa. Maybe India was the origin of it, but most likely it originated in Africa and then went out. This map is provided from another research article. It's could be a little confusing unless you take the time to look at it. And what it shows is the phylogenetic inference, and that means that it appears that the spread that took place along the lines of those red arrows, they were able to trace by the phylogeny or the genetic makeup of the virus itself. The trajectory that they show there is it went from Uganda, both west to Nigeria and West Africa, and then east, out into the Indonesian subcontinent, and then out of the Indonesian subcontinent back up to India, and then up and across and out into the Polynesian areas of the Pacific. And from the Polynesian areas of the Pacific, we know now from tracing it that that's the same virus that appeared in Brazil in March of 2015 when it was first noted in people and isolated. It has since spread from there by case distribution. It says inferred case distribution. That means somebody with the virus or a mosquito that was carrying it was picked up and transported into a new area. And what happens in the case of an epidemic like this, where you've got a very large naive population, both in the people that are exposed to it, and a very, very capable host, a very capable vector, which is in this case is the Aedes mosquito, and we'll go a little bit more into that in a while about that mosquito. But the very widespread, very capable vector, and it has spread very, very rapidly in the Americas. Next slide. A man by the name of Edward Hayes, in an article on Zika Outside Africa that was published in 2007, said that I should, either through serological associations or actual virus isolates, this virus has now been widely reported in tropical and subtropical areas of West Africa to the Yap Islands in the Pacific. Well, that was in 2007. What happened to get it from that particular area into Brazil, which is the first area it was noted in the Americas, was they believe that there was an international canoe race held in Brazil in 2015, 2014, late 2014, and for which the Polynesians sent a team. We believe that one of the people, at least on that team, must have had Zika virus, brought the virus into an area where there's ample vector mosquitoes and a susceptible population, and it was introduced there then in March of 2015. Next slide. What is Zika virus? Zika virus is called a flavivirus, flava meaning yellow. The first one of these viruses that was identified as the yellow fever virus. And is characterized. That virus is characterized by and the disease it causes by a significant yellowing of the skin of people who have it. It is a very fulminant disease. It's very what would I say? It's virulent, and it sweeps its way around the world on a regular basis. It fascinates me in that in the early 70s, I should say, I was assigned to Panama, where I was teaching Navy physicians tropical disease recognition and doing research on another disease called Chagas disease. It's caused by Trypanosoma cruzi. And I was down there to do that. Well, I happened to be working in Gorgas Memorial Laboratory. And in Gorgas Memorial Laboratory, one of their big projects was to track yellow fever as it tracked around South America. And it appears that that particular virus goes through a cycle where it runs a front that runs in a circular pattern around the outside of the Andes, around South America, making a sweep through an area about every 3 to 5 years as a new naive population of hosts are available, and the hosts being, in this case, monkeys that dwell in the treetop, the vector being a mosquito that dwells in the very top layer of the canopy of the jungle, and that one's called sylvan yellow fever. Well, as we all know, in Central and South America, one of the ways of making a living is it's called slash and burn. They cut the jungle down, they plant the jungle floor with a couple of rice crops, but in the process of cutting that jungle down, they bring down that top canopy, and a worker will be out and cut down a tree, and all of a sudden find himself covered with some blue metallic-looking mosquitoes. They were called Sabethes at the time, but they've been reclassified, and right now I don't recall exactly the classification. But those little mosquitoes then transmitted that yellow fever virus to the worker, who then went out and back into his village, where he was exposed to Aedes mosquitoes, and the Aedes mosquitoes proved to be very capable vectors, and picked it up and transferred it into the human population. So we have, every now and then you'd have it transferred into people, and then a whole sweep of that virus would start itself around South America. And in the particular case that I'm talking about, it made its way up through Central America into Panama and all the way up to Costa Rica then in that year. And it's the Flavivirus the Flaviviridae is a family in which there are 4 genera, and one of those is the Flavivirus genus. And all of the Flavivirus genus are transmitted by arthropods, either ticks or mosquitoes. And next slide. Okay. This particular slide shows you a picture of an Aedes mosquito taking a blood meal. The Aedes species are the ones that are proven to be very, very capable hosts. This is a particular one is Aedes aegypti, which is the most widespread of the Aedes species. In fact, is found worldwide. Next slide. Okay. So Aedes aegypti is one, Aedes albopictus is another, Aedes africanus, and there are others, but in particular the two that we're going to be watching as far as the spread of Zika are the Aedes aegypti and the Aedes albopictus. Next slide. This map shows you a worldwide picture of the distribution of those two particular species of Aedes. And you can see in all the low-lying areas of the world, in the tropical and subtropical regions, Aedes are present. The Aedes mosquito is what we call it's an urban mosquito. It is a day biter, and it is a container breeder. It is very large, and it is very prolific, and is very difficult to control. which makes it, for the virus's sake, very ideal the vector. For our sakes, it makes it a very, a very hard vector to control. There, you will have noticed in the literature lately there has been a lot of information available about trying, genetic alteration of different mosquitoes, where they genetically alter the male, the sperm from the male is then fertilizes the female. The larvae are pick up this genetic alteration, which causes them not to survive to adulthood. And so cutting down on the availability of good male, not vectors, because the male is not a vector, it's only the female, but of a good male, a sperm donor, for that will cut down on the population. So far, these have been unsuccessful. And in fact, there's been some speculation that messing with this mosquito genetically may have been contributed to some of the changes we've seen in the virus. That is pure speculation at this point in time, but you hear that out there a lot. I've heard it more than once from people saying, yeah, if man hadn't messed with this mosquito, we wouldn't be dealing with this, this modified virus that we're now dealing with. Next slide. This is current known distribution of Zika virus. In fact, current up until the time this slide was produced. It is spreading very rapidly. Now it's located around the world. It has reached the stage of what we would call a pandemic, and which means that it stretches around the world. And there are, as these countries that show here, locally acquired, or what they call autochthonous infection. That means transmission within a particular country, and then those countries where we know it has been because of serosurvey data. What has happened in those countries where we have the serosurvey data and we have not seen autochthonous transmission does not mean it's not there. It means it is there, but the level of it has now reached the level of what we call endemicity. It's endemic in those areas, and the threat or the risk of exposure to that particular virus in those areas is very small. Next slide. What happens with Zika is that it begins with the introduction of the virus in the body through the bite of the infected mosquito, followed by an incubation period of a few days to 1 week, and then followed from that by an infection, which is characterized by mild to often subclinical. 4 out of 5 cases go unnoticed in the infected individual. So, like again, just to repeat, when it got introduced into the Americas, there was very little attention paid to it. We knew that it would spread rapidly, but it was such a mild infection that not too many of us it didn't get our attention the way that it should have. Next. Okay. Most common symptoms of Zika are very much typical of the Flaviviruses of fever, rash, joint pain, conjunctivitis, and other common symptoms include muscle pain and headache. And from the time of exposure to the time of symptoms, which is the incubation period, the virus disease, it's not really known, but it's likely to be a few days to a week. As I said, we're still, this is so new, we're still discovering a lot about it. The one warning that CDC puts out, and this is copied from CDC's website on Zika virus, the one thing they put in is see your health provider if you're pregnant or develop a fever, rash, joint pain, or red eyes within 2 weeks of traveling to a place where Zika has been reported, and be sure to tell your healthcare provider where you travel. That's good advice no matter where. If you travel, as many of us do, you're exposed to many areas and many things, and a lot of diseases that are endemic to particular areas. So your healthcare provider, knowing where you've been, will help them in dealing with your diagnosis. Next slide. As again, to repeat, and I'm just got the CDC website here so that you know that, is the illness is usually mild with symptoms lasting several days to a week after being bitten by the mosquito. People usually don't get sick enough to go to the hospital, and they rarely die of Zika. And for this reason, many people might not even realize they've been infected. Zika remains in the blood of an infected person for about a week, but it can be found longer in some people. We're still delineating where this virus goes in the body and how long it resides there. Some of the new areas that it is has been shown to go as it goes into the mammary glands in women, but there have not been shown that there's been transmission to children through the mother's milk. But we know it's there. We know that it gets into it's been isolated from the amniotic fluid in pregnant ladies, and it's been isolated from the seminal fluid in men. The usual course of infection is it's in the blood for about a week, and and like I say, can be found longer in some people. But then, the immune system of the host kicks in, and the person clears. And once they clear, the infection, they're thought to be immune from future infection. Thanks. And I said, put here, so what changed to bring about the world's attention to this outbreak that we're now witnessing? And I'm not seen one like this before. It's very hard for anybody to keep up with the amount of attention that Zika virus is getting. One is we've had a recent and I think well-intended and well-received focus on maternal child health around the world. And so when this disease first showed some propensity to or some association with the outcome of pregnancy, it drew a lot of attention very quickly. And that's why, and quoting there again, that statement that was in recessed, a subparagraph on the CDC thing is that, if see your healthcare provider if you're pregnant and develop a fever, rash, joint pain, and within 2 weeks of having traveled to a place where Zika has been reported. There's a lot more guidance that's out now, and we'll cover some of that. And next slide. Go back to, how it got where it's at. And, we're sure phylogenetically that that's when it came out of Polynesia. That's important because something has happened with this virus. None of us at this point in time know what, but it is somehow modified in its pathogenicity. And we believe that it began to occur or did occur in Polynesia. And next slide. The website, again, put it this way. We're searching for new mothers in hopes of solving one of the world's most urgent public health mysteries. Is the Zika virus really causing microcephaly? Now, microcephaly is a type of birth defect where the formation of the skull and head of the child is impacted, and the child is born with reduced both of cranial capacity and leaving them, as it says in this quote here, with shrunken heads or badly damaged brains. The preponderance of evidence at this time points to Zika being the culprit. Megumi Itoa, a lot of people are working on this at CDC, says, but we don't know for certain yet whether this, but so this is one way of finding out. Let's go to the next slide. Excuse me. Okay. And an article that was published in February of this year, 25 February, so it's very recent, Zika virus and neurological disease approaches to the unknown. And this also came from the Lancet Infectious Disease Journal. Solomon again states in that phylogenetic studies suggest the virus emerged in East Africa in the early part of the 20th century, spreading Southeast Asia. And in 2007, there was a small outbreak in Yap in Micronesia, and in 2013, a larger outbreak that took place in Polynesia. In that particular outbreak, there were 28,000 cases recorded in the first 4 months of the year. Next slide. Okay. Then in March of 2015, again, thought to be associated with the Polynesian canoe team arriving in Brazil, it began to be reported in Brazil. Its spread has been rapid to the point of being considered explosive, with a predicted 1.5 million cases to 1.5 cases, with 4 million predicted across the continent of South America by the end of the year. This has led the World Health Organization to declare a public health emergency of international concern. This is a relatively new declaration level that came into being with the problem that we saw with Ebola in West Africa. This declaration has brought money and attention to this virus, and therefore what we've seen is this flood in the literature, like I say, that is at the point of it being difficult to keep up with. Next slide. In Polynesia, the virus outbreak took place in 2013, and in retrospective studies now have gone back and looked and said, there was an increase in Guillain-Barré syndrome. Guillain-Barré syndrome being a disease that affects the nerves and the ability to transmit signals to the muscles and can result in paralysis. It is self-resolving over time, provided it doesn't really get advanced, and is treatable. But there are a number of conditions which can lead to a number of diseases and other conditions that can lead to Guillain-Barré. But in this retrospective study, they noticed that well, yes, we did see an increase in the Guillain-Barré syndrome in that particular area. This also seems to be the case in Brazil. And the details at this point are scant. They're still coming in. We are still, the scientists and the medical researchers are still out there very actively exploring this. Next slide. The thing that has changed here is the number of children reported born with microcephaly has increased dramatically in Brazil. Retrospective studies have gone back and looked at that, and there's been confusion because about the same time as this increase was noted, Brazil changed its case definition of microcephaly, making it more inclusive, and therefore many children that would not have been previously diagnosed as microcephalic were diagnosed. The researchers have now gone back and taken that new parameter out, and still, that association is there. There is a very notable increase in microcephaly in Brazil by any standard. And what they have done is gone into a number of those cases where they can do retrospective studies and taken serum from the individuals, from the mothers and from the child, and found antibody to the Zika virus. And my statement out there that although strongly suspected the causal relationship between in vitro exposure to Zika virus and microcephaly is yet to be established. Next slide. Give me a second. The other thing that has happened, and we've noticed, is there's been, and when infection occurs in pregnancy, it can also result in infants born without microcephaly, but with more subtle neurological and developmental abnormalities. Excuse me just one second. I'm back. I'm sorry. The new thing that has come about, and it says the potential for Zika virus transmission in semen or through blood transmission is causing additional concern. When Zika first came to our attention, we were aware of one documented case of where a gentleman had traveled extensively in an area of Zika transmission and then returned to Colorado. And subsequently, his wife, who had no exposure to the vector mosquito, came down with Zika virus infection. That was the only way. The only way she could have gotten it is, is speculation that it was transmitted through, and sexually from the man to his wife. Since that time, there have been more documented cases of that. In fact, the number of documented cases of sexual transmission in the United States is now at 14. And with the sexual transmission now being reported in 2 additional countries worldwide. My speculation as an epidemiologist is this is a much more common way of it being spread than we're aware of. When you look at what's obvious in front of you, it's a Flavivirus. It is a arthropod-borne virus. It's transmitted by the mosquito. We don't look too much beyond that, except that all right now that occurred in a couple of areas in the United States or other areas where we don't have the vector mosquito. How did it happen? Well, it happens by, in this case, by sexual transmission. Therefore, it brings the additional concern of a woman who is either pregnant or is anticipating pregnancy as part of her family planning. And has a husband who travels in the area where Zika virus is known to be transmitted, now has a new concern. Next slide. Okay, the fact is that there's been one case in blood transfusion where it's been transmitted. I'm sure that that's a possibility. It's not one that arouses a lot of concern with us, but in case of the sexual transmission, it does. And if I put down at the bottom that why is this important? Next slide. It's important because of the possible effect that this virus can have on the fetus in pregnancy. We know that it crosses the placental barrier. It goes transplacentally. We know we've isolated the virus now from amniotic fluid. We know that the newborn or the fetus while in the womb can become infected. We also know that the sequela of such infection can be anything from the microcephaly, which we'd say casual versus causal. Which one of those is it? What we're doing is we are getting more and more evidence, and it's coming in hot and heavy now, that it is a causal association and not casual, and that there are other births, there spontaneous abortion, there is other neurological damage that's occurring, and we're having stillborns born at a higher rate than usual in Zika transmission areas. Next slide. Again, is this a causal or a casual association? And as I say, and just evidence that's coming in just this week, pointing more and more and more to the fact that it is causal, that it is the virus that's doing this. Next. Okay. There's also, as I said, there's been increases in the report in stillborns and spontaneous abortions reported throughout the Americas, but particularly in Brazil in relation to this outbreak. And that's because in Brazil, what we've got is a number of infections amounting into the thousands. Means that we've had a lot more exposure of women in pregnancy or becoming pregnant or sometime, prior to delivery that have become infected. And so we're seeing this outcome. Next. I'm going to mute my mic here just so I can take a drink. Okay, I'm back. Am I back, Beth?
Yes,
Okay.
we're ready for you.
Also, we've noticed this increase in Guillain-Barré, and in retrospect, I said we went back and found that in Polynesia, and now we're finding it throughout Central and South America. Again, particularly in Brazil, but I hate to keep hitting the tail on the donkey with Brazil, but what it is just the number of cases. That's where it started here. That's where the focus has been, and so all the researchers are pouring into the area, and so we're getting a skew in the data that's coming from there versus other places where this virus is newly being introduced. And it's going to take a few years for this to play out. But other than the fact that we know that this virus, as with other flaviviruses, has a neural, impact, and that in the case of adults, anywhere from a few days to a few weeks after having come through a Zika virus infection, then we're having people that are coming down with temporary paralysis and then the diagnosis of Guillain-Barré. So this is one to be reckoned with, and causal or causal, the evidence is pointing very, very strongly toward causal. Next slide. Other questions that that you can include in this is how long does the Zika virus survive in the seminal fluid of infected male? Nobody knows at this point. If it is like in the case of Ebola, where we have found it to survive as long as 3 to 6 months in the seminal fluid of a male who has survived the infection, we know that the person has circulating antibodies to Ebola. But those antibodies don't reach into the seminal fluid, and the virus survives there. And we've had renewed outbreaks take place in a couple of areas in West Africa that have been very definitely traceable back to sexual transmission. So, until we're very sure of how long the Zika virus is able to survive in seminal fluid, then instituting protection of the woman from infection by sexual transmission associated with anything where she may be or may become pregnant is something that is of concern. The United States has gone far beyond any other country in recommending both either abstinence or the use of condoms, for the protection from transmission from the male, from the husband to the wife, but CDC is recommending 1 year. Other countries are say going down to 2 incubation periods. Which one of those is good and how far is only anybody's guess right now. But the best thing to do is to be as careful as you can. And if Zika virus is not responsible for the increased reports of microcephaly newborns in Brazil, then what is? Where is this epidemic going, and what changes contributed to the phenomena that we're seeing? Those are all questions that we have at this point in time. Next slide. Okay. Other questions are, what changes contributed to the phenomenal increase in the speed of spread that we're witnessing? From 1947 to 2007, we watched it spread, from Africa, very slowly across, the sub-Asian continent, India, and then out into the Polynesian islands. But once it hit Polynesia, something happened, and I cited the number of cases that occurred there in the thousands, and a very widespread group of people among isolated islands, and then in Brazil, and from Brazil throughout now the Central Caribbean, throughout, and we expected in the United States this summer with the onset of the mosquito season. It is throughout, along the coast of Mexico. It is now spread into Bolivia, into the low-lying areas of Bolivia, where these mosquitoes are, and it is, something happened. We don't know what at this time, but that's, that keeps us epidemiologists guessing, and the scientists busy investigating. So next. There's I'm sure you have questions. If you don't, I think you should. Particularly since we deal with such a highly mobile group of people through Samaritan's Purse and other international organizations where travel is a part of what we do. So as those questions occur to you, feel free to, I want to take this time and answer them as best I can. I'm not an expert. Not much more than anybody else, other than the fact that when I read about these things, for some unknown reason, they make sense to me. But this one is a phenomenon, and a curiosity, and it's what keeps me coming back to getting up every morning, go to my computer, saying, okay, what happened overnight? Okay. Questions?
Thank you, Dr. Tom, for just this great presentation. It has certainly, you've given us great information, but also leaves a lot of questions, I think, unanswered. And I'm sure we have questions from our audience, too. So I just want to remind you, if you have a question, to please put it in the chat box, and we can ask Dr. Tom that. We do have one question that's come in, and I just want to ask that to you, Dr. Tom. Is there any hope that this epidemic will die down spontaneously, or are we facing a situation that could end up like the HIV pandemic that we saw earlier?
The only thing we could hope for in the die down of where this is going would be, whatever happened that mutated or took place that made the virus, much more capable of spread and then of causing the symptoms, and the outcomes that we are now seeing would be, something to happen to reverse. That's not likely to happen. This virus is now very successful. And doing that, I think we're going to continue to see the spread. In epidemiology, from the standpoint of an epidemiologist, what we see, what causes an epidemic. You have an introduction of a new agent into a new environment. It perks along in the background at a low level for a number of months, years, days, and until it reaches what's called the epidemic threshold, and that's when an ideal combination of the agent's ability to cause infection, that same agent's ability to cause infection, a very susceptible, naive host that's never seen this particular agent before, in an environment that's very supportive to bringing both the agent and the host, the person, into the same environment, so infection takes place, and then an epidemic takes off. When it takes off, it gets into what's called an exponential phase, which means it doubles in the environment exponentially, which means the curve of infection is what we're seeing now in the Americas. But eventually something comes along, and that's called, the host begins to develop. The number of available hosts gets reduced because the ones that are there are becoming immune, or the season changes and the virus, and the vector doesn't do as well. But the epidemic will die off. What we are left with is a large proportion of immune people in the environment, but then not without enough naive hosts to continue the virus at the epidemic level. That's when it becomes endemic in the environment. And it makes its way around until about every third or fourth year. What happens is the immune levels, decline. There the introduction of new naive hosts, and we'll have another blip of the epidemic, but it's small. So we're looking at the fact that now Zika virus is endemic around the world, much like dengue, which is one of its cousins. And dengue epidemics happen in different countries all around the world every year. And I think that's what we can look forward to.
Mm-hmm. Well, great information. It doesn't sound like it's going anywhere anytime soon, unfortunately.
Unfortunately, right.
Another question we have is, if a woman has Zika and recovers, at what point is it safe to become pregnant?
Like I say, we're still looking at this one very, very heavily. We would assume, and we all know what that word means, but we would think that Zika, that once a woman is immune, that she no longer has the virus present, nor will she spread it to the offspring. So having survived that and a couple of weeks out after infection, that should be safe. That said, recognize the fact that this wasn't even a problem, a year ago.
Sure.
And so we're still looking at that one and that information. If good places to go look. If you happen to be a Twitter fan, just go on Twitter and search hashtag Zika virus. And all the latest information that's coming up is just, it comes up on that. There is a WHO forum that you can get to off of that page, and it will bring you the day-to-day updates on the discoveries that are being made. So, those people who are really concerned about it and have the time should, stay, and if you travel in the areas where this disease is now becoming endemic, and where it is epidemic and becoming endemic, then I think it would be, help yourself, to be, what's going on.
Thanks, Dr. Tom. Can you address the hope for a vaccine, or where are we on that?
The thing about vaccines is, everybody looks at those as the panacea. But vaccines are expensive. For one thing, development is very expensive. Yes, there is research going on. Yes, the track will be cleared from a number of the, what would you call it, the bureaucratic impediments to the development of new vaccines because of the impact this is having. There are vaccines out there that, that should work, since we know this is a virus that is very susceptible to the host immune system. But I think we're looking at least 2 years out. The only thing comes after that is then, okay, what do we use that vaccine for? 2 years from now, this should be endemic, not epidemic anymore. It's no longer economically feasible, and that's a hard word to use when we're talking about human life, but economically feasible for drug companies to produce the vaccine in large quantities because it would not be bought or used. So what we would then be looking at then is something called ring vaccination, so that if an outbreak took place someplace, then we would go in and vaccinate a whole ring around that of people to put a barrier up to the spread of it out of that particular area. But the promise of a vaccine to stop this thing now is very real.
Mm-hmm. Challenging. What recommendations do you have for our current Samaritans Purse programming to prevent more infections?
That's a difficult one. We cannot prevent more infections. They're going to occur. This particular mosquito that transmit this guy, that is a very, very capable vector. The Aedes species, they're hardy. They are, as I say, container breeders. What that means, and for those of us who live in areas where they may be breeding, and one of the things you need to do is they pre-breed everywhere in very small amounts of water. And we find them in the catch pots underneath flower basins. So if you pick up that basin and happens to have a little water in the bottom of it, quite often you will notice thousands of larvae in there, and those thousands of larvae are Aedes. So dumping those out, a tin can, a plastic bottle left beside the road that can gather water in it becomes a very ideal breeding place. So it's a difficult one. It's one we're going to have to address. It's one that Brazil is working very hard on right now, and, but their efforts are meeting with limited success because of the competence of the vector.
Sure. Can you address a little bit about males being tested to see if they're a carrier for the Zika virus? Is that a possibility, or what? Maybe address testing in general. How do you get tested for Zika virus? How easy is that to do? Should people be tested for it?
It's what we call a PCR test, and it is available largely now in the United States only through CDC. CDC is interested because they want to know where this virus is at in the United States. Your healthcare provider would have to, arrange for you to have a blood specimen drawn and sent off to CDC for testing. They're not going to be wanting to test anybody that haven't been traveled in an area where the transmission is taking place, or for the case of the woman, as her husband has traveled in such an area. And the other thing they're going to be looking for is was the person symptomatic, or they would be flooded with people coming back from travel and wanting to be tested, and they don't have the capacity to handle that. So they're going to be looking at clinical reasons to test. As far as testing the male to see if he's a carrier, that would mean that they would have to gather seminal fluid from that particular male and do tissue culture to see if they could grow the virus out, which is an extremely expensive test and time-consuming and not likely to happen. And what they're asking everybody to do is, if you've traveled in an area like that where it's been, if you have been bitten by mosquitoes in the areas, that you have to assume that you may be carrying.
Mm-hmm. All right, I think we'll maybe close with this last question for you, Dr. Tom, and it is, what elevation areas does the mosquito cease to exist or to be an issue? Is elevation play into this?
Yeah, elevation, it's difficult to say. What we're looking at is in areas that have hard freezes, or I would say that, speaking for part of our audience, we're looking at about 1,000 meters. For the rest of us who deal in feet, about 3,500 to 4,000 feet. Mm-hmm. You'd have to get into New Mexico, and even parts of New Mexico, in the United States are there. But what we're dealing with there mostly is the coastal and areas of central and south of the United States, Florida, throughout Mississippi, Alabama, and all the way up the coast into North Carolina, throughout Texas, and then down the Mexico coast and up the other side into Southern California, as far as the U.S. is concerned. But then like I say on that map, all you got to do is you just go on Google and say a map of Aedes distribution, and it'll bring up a map and show you.
Mm-hmm. Well, thank you so much, Dr. Tom, for this great information, and we appreciate your insight into this particular topic. I'm sure there's a lot more questions out there, and just encourage you to visit the CDC website and those websites that Dr. Tom has mentioned. I want to remind you, if you want CME for this presentation, that is available, and that you do need to send that in by the specified date to your attendance, and by the specified date that we give you in the email, and also need to submit your answers and fill out the evaluation form, and you send that to the email address Orlando Health to receive that CME. You will get if you're signed up for to receive notifications for our webinars. They do happen once a month. We are excited to have our next month's webinar on April 13th. The topic will be neonatal care in low resource settings. So we hope that you join us again for that. And with that, we will conclude our presentation today. So thank you so much for joining us.
Thank you.